Okay, we're good.
Perfect. Thank you, Kathy. Good morning, everybody. I will start by calling our meeting to order. First thing we need to do is take a roll call vote of members present, and I'll ask Kathy to do that and start the roll call for this and all other votes. Thank you.
Okay. Rebecca,
Present.
Michael,
Present.
Elaine. Okay. Bella,
Present.
Eric. I thought I saw you. Okay. Martha,
Present.
Robin,
Present.
Dimitri, Secretary,
Here, present.
Nancy. Nancy?
Do we have a quorum?
Yes, we're okay.
We do if I unmute myself.
Oh, okay, here we
Good
are.
morning, Kathy. Sorry for
Morning,
my
Nancy.
technological ineptness, and I am here.
Okay, and last, Matt. Okay. We do have a quorum.
Terrific, wonderful. So stay unmuted, everybody, because the next item, or the first item on the agenda is approval of the minutes of the April 11th meeting. I'll entertain a motion to approve those minutes.
Motion to approve the minutes of the April board meeting.
Thank you. And I think
Second.
Nancy's a second. Great. Now we need to call for a vote again. Kathy, we'll do the roll call, please.
Okay. Rebecca,
Aye.
Michael,
I was absent last meeting, so I think I need to abstain.
okay. Just in case you hopped in, Elaine, I didn't see. Bella,
Aye.
Eric, in case I missed him.
Yes.
Okay. Martha,
Yes.
Robin,
Yes.
let's see if Dimitri. Okay. Secretary Walsh.
I think I abstain as well.
Okay. Nancy
Yes.
and Matt. Okay. Thank you, everyone.
Terrific. The motion carries. Now we're done with the administrative part of the meeting. We can get into the meat of it, and that starts with Audrey's report, our executive director's report. Thank you.
Thank you, Secretary. Good morning, members of the board, and welcome to today's meeting. It is great to see you all today. Today's agenda is primarily about looking ahead as we continue our work to make our marketplace work better for our customers and the people who need access to healthcare from us. The largest scale of these items is our strategic plan, a 5-year action plan that kicked off with your support earlier this year. Our presentation today is not a rehash of the plan itself, but rather a brief progress report detailing highlights of the way the plan is being translated into detailed streams of work throughout the Health Connector. Since the board approved the plan back in January, we have captured and reviewed nearly 90 active agency work tracks and taken steps to update and align them with one or more of the 4 focus areas that are the pillars of the strategic plan. We're excited to share these particulars, both for board feedback and awareness, but also in the spirit of transparency to you, our governing body, and to the public more generally. One of the 4 focus areas in the strategic plan is improving equitable access to affordable health insurance. And a part of that evolving work is our commitment to pushing ourselves to make sure we're capably supporting members of the public who do not speak English as a first language. So today, our second item is an overview of our language support to members and applicants. Historically, populations that don't speak English as a first language or have other language barriers have a greater chance of being uninsured compared to the general population, meaning we need to be laser focused on making sure these residents have additional support to protect their on-ramp into getting and staying covered. This work is a key feature of the Health Connector's equity-centeredness. We will share for you today an overview on our language access supports where they stand today, including highlights on recent updates made, including improving our HICS and notice experiences to include Brazilian Portuguese and moving to 711 mass relay services. This change will ensure that callers who are deaf, hard of hearing, or speech disabled have the best customer service experience and the most updated technology available. We will also detail additional planned expansions and improvements in new language capacity and our public-facing services, improvements in our data and analytics related to new enrollment, and overall customer service of individuals who need language support. Today, we will also update you on federal regulatory changes and activities and their impact on marketplace eligibility and operations. It has been a busy period in recent months as the Biden administration has released a wealth of healthcare-related regulations that touch us and the members we serve, regulations that the Health Connector has expressed support for during the rulemaking process. Notable in the recent actions is a non-discrimination rule for the Affordable Care Act, known as Section 1557, with a goal of ensuring non-discriminatory access to care for all, including women, people with disabilities, LGBTQI+ people, people with limited English proficiency, people of color, and people regardless of age. We already comply with many provisions of the rule, but are reviewing notices, policies, and training to ensure they reflect the rule's updated provisions. Additionally, the administration is expanding the definition of lawfully present to allow individuals with deferred action on childhood arrival status, or DACA recipients, often also known as Dreamers, to qualify for marketplace plans and subsidy. DACA recipients are already covered up to 300% of the federal poverty level by Mass Health, but we are reviewing implementation pathways to ensure anyone eligible for Health Connector coverage because of this change has access starting this fall. We plan to reach out to DACA recipient communities through local, non-English media, targeted advertising, and creating or expanding partnerships with local immigration service community organizations to increase awareness of this new coverage option for Dreamers. The last agenda item today asks for your approval of expanded work orders with Amazon Web Services, or AWS, cloud services. Since starting work with AWS in 2017, the scope of our work and needs have increased, and this expansion will help meet ongoing needs, including expanding our internal data analytics and reporting platform. All of this forward-looking activity in the second half of the year and beyond comes after our first and second quarters were marked by success in executing two of our most significant organizational priorities: completing the Mass Health redetermination process, which resulted in record Health Connector enrollment, and launching our Connector Care pilot expansion. We continue to outreach newly eligible people moving from Mass Health, and will this summer message people who appear to have been out of Mass Health coverage for several months to encourage them to take advantage of enrollment opportunities if they still need them. And we'll reach out to those in Health Safety Net to make sure they understand they need additional coverage to be compliant with state minimum creditable coverage standards. We continue to await for more complete data on the transition and churn over the last year, but early indications are that the Commonwealth was able to successfully stave off material reductions in overall coverage, the risk we all rightfully worried extensively about a year ago and took careful actions to prevent. We will be thoroughly studying forthcoming state data that will help us understand the post-redeterminations coverage landscape and if any populations need additional support to enroll. In the meantime, we're preparing a report with initial data and insights from our Connector Care expansion population, which is currently comprised of about 51,000 employees. The report will include a demographic and geographic analysis of membership, along with some initial firsthand detail from those members via a recently fielded survey. We anticipate the report being ready this summer, and we look forward to sharing it with you. Lastly, also in the looking ahead category, I want to note that the upcoming federal elections this November are on our radar in terms of their capacity to alter the national policy landscape in which ACA marketplaces like the Health Connector operate. Our policy team is conducting an analysis of the impact of various outcomes of the elections as they relate to control of the White House and Congress, all of which are very much in play, as we know that shifts in policy can and do have significant implications for us here at the state level. We will have more to share with the board in the coming weeks and months as we consider state-level preparedness for possible scenarios. Among other elements of federal policy in question is whether or not enhanced ACA premium tax credits, currently slated for expiration at the end of 2025, will be further extended. The consequences of that decision at the federal level will have material impacts for Massachusetts. We currently have roughly $222 million annually flowing into the Commonwealth to lower health insurance premiums for Massachusetts families, so the stakes are high. Through the state marketplace network, we're plugged into the congressional discussions that may precipitate strategic choices about how and whether extension is pursued in a legislative vehicle. We will keep the board posted, as well as other healthcare stakeholders in Massachusetts who will certainly want to be engaged in the national conversation on the impact of potentially letting those supports expire. Turning our eyes back to today's agenda, I want to thank my staff for their careful work planning for today's presentations and all of the daily work represented by them, and thank the board for their support and engagement on these topics and all of the work we do together. So with that, I will hand it back to Secretary Walsh to take us into the balance of the agenda.
Thank you, Audrey. Any questions for Audrey before we jump into the strategic plan? Okay, let's get going. So next up is the update on the strategic plan, the 2024 through 2028 strategic plan, and Nuri and Erin are leading us through that. And I think Nuri is kicking us off.
Yes. Thank you, Secretary.
Good
Just
morning.
make sure
Yes.
I can advance the slides here. There we go. Good morning, everyone. As Audrey and the Secretary noted, Erin and I are here today to provide you with an update on our 2024-2028 Health Connector Strategic Plan. This is the first time that we come before the board with an update since the plan was presented and approved at the January meeting. During today's presentation, we'll review the work that we have done since then, as we are now in the first year of implementing the strategic priorities into our everyday life and the work that we do. We will review our implementation approach, outline the goalposts for 2024, and share our next steps. Since January, we have pivoted to developing a framework for implementation. The process included establishing 2024 agency priorities in order to embody the strategic plan. And as part of that process, we determined the need to identify our current work, projects, and initiatives that are being pursued in 2024 or will be pursued this year. Second, align our current work with the strategic plan principles and really seeing how each work advances each of those principles. Create a system to monitor and track progress of the work streams. And lastly, create a structure to be able to report on the progress of our work towards key milestones within each of the work projects and the impact that we expect the work to have, not only internally on our staff, but also externally on our members, residents, and public as a whole, and other external stakeholders. This slide here is a reminder of each of the key areas of focus outlined in the strategic plan. So starting at the top left corner, we have improve and modernize the applicant and enrollee experience, maintain and strengthen organizational structure and system reliability, improve equitable access to affordable health insurance coverage, and lastly, deliver high-value coverage options to the residents of Massachusetts. And I will note the DEI, diversity, equity, and inclusion, that is woven throughout the strategic priorities, the plan itself, and all of the work that we do here at the Health Connector. Now, if there are no questions at this time, I will hand it over to Erin, who will provide a high-level overview of the work within each of those focus areas and what we expect to see.
Great, thank you, Nuri, and good morning, members of the board. As Nuri noted, we will now walk through each of those 4 focus areas of the strategic plan and review at a high level some of the work streams within each area that the Health Connector will be focused on over the next 12 to 18 months, and the expected impact that this work will have on our member experience, our work with partners, and our success as an agency. While I will not walk through the work tracks one by one that the Health Connector has identified and committed to making progress on over the course of 2024, the details of this work and our progress can be found in the milestone report on the Health Connector's strategic plan website. So the first strategic area we will review is improving and modernizing the applicant and enrollee experience. Health Connector work streams in this strategic area are dedicated to advancing 2 key goals: ensuring that residents can easily obtain and maintain coverage, and improving how residents and members interact with the Health Connector digitally. With respect to enrolling and maintaining coverage, the Health Connector is actively engaging in work that improves upon an applicant or member's ability to complete the application, their ability to respond to calls to action and communications, and their ability to access the supports and information needed to maintain coverage. This includes work that expands allowable forms of identification a person can submit during the application process, as well as revisiting the organization and language of our communications and notices so that critical messages are not buried within text and individuals can take the action required of them to When we think about work that will improve how residents and applicants engage with the Health Connector online, active work streams focus on improving the digital experience for both the non-application-based Health Connector website and the application and enrollment website that we refer to as the HICS. Improvements will enable individuals to find the Health Connector's informational website with greater ease through efforts to maximize search engine optimization, and will also enable individuals to find important and relevant information within the non-application website more easily as we work towards a refresh and reorganization of the Health Connector's informational website. Additionally, through upcoming technology releases, language on the application will be reorganized and revised, providing a more user-friendly experience with the expectation that more residents will be able to complete the application independently. We can move, oh, go ahead, Eric.
There we go. As we're looking midterm and long term, I would want to just add that in private industry, at least, we're seeing tremendous strides with AI as it can be leveraged to enhance the end user experience. And it may make sense, I'm not saying to implement it, but I'm saying to keep tabs on where it is and how it might be leveraged. It's such a powerful tool, and it can learn so fast. I'm seeing it firsthand. There's just it's progressing so fast, and it can be so helpful. So just encourage you to include that on your list somewhere.
Thank you, Eric. Absolutely. And agree. I feel as though it's increasingly becoming more apparent, and so something that we absolutely as an agency want to look into more. How we can leverage that, and we'll certainly leverage our relationships with the board as well as we go, embark in that space. Any other questions or comments on this slide before we move on to the next focus area? Okay. So the next strategic area and work streams we will walk through are focused on the Health Connector's commitment to strengthening both our internal and external operations and functions. When we look internally, this work includes investing in and elevating staff by establishing and developing a formal learning and development program for new hires and existing staff, as well as providing robust professional development and training opportunities. Operationally, this work also includes revisiting and strengthening internal processes to minimize disruptions in Health Connector day-to-day business and rethinking how we engage with external partners, reorganizing our approach to allow for greater efficiencies and more proactive thinking and planning with our external partners. And so while all of this work in itself is important and will have significant impacts, we recognize that everything we do at the Health Connector ultimately trickles into our work with the public and residents of the Commonwealth. So I'll pause here for a moment as well for any questions or comments. Okay, if none, we can move on to the next strategic area.
I have one question on this topic. This includes overall IT security. Is that correct?
When referencing internal kind of strengthening our systems, yes, absolutely.
Okay, this is probably more Dimitri's area of expertise, but I assume we include penetration testing and those types of processes as part of our best practices. Cybersecurity is so important.
It is. And Eric, I'll just share, we have an active workspace on all things security that we've ramped up over the last year in light of, all of the various incidents we've all been witness to with carriers, other marketplaces. So we'll have more to share with the board, having completed an analysis and assessment of that, and then what that translates into in terms of new processes and measures at the connector. So more to come, but that is 100% in kind of the four squares of this area in terms of making sure we're completely shored up on that front.
Okay, thank you.
Of course.
Oh, thank you. Great question. So this next strategic area covers the work the Health Connector is focused on with respect to increasing access to affordable health insurance coverage through the expansion of member supports and the use of enhanced data and analytics to better understand and respond to the needs of residents. While there are existing channels that provide great support to residents and members currently, we recognize there are always ways to build upon what is working well and a need to continue to innovate. So work in this space is focused on adapting how existing programs support our members to better reflect and meet the needs of residents. So for example, strengthening the relatively new community specialist program so the Health Connector team can be in communities with greater need, regularly visiting community locations like libraries to provide in-person supports, and creating new channels to engage with residents, including establishing a new approach to community engagement that will create a way for the Health Connector to incorporate and respond to feedback and the needs of our residents in our work. The Health Connector is also focused on how it can better use data and analytics to improve our understanding of the changing needs of Massachusetts and its residents. This work focuses on researching and monitoring the changing population of Massachusetts and what that means in terms of needs for practical and community supports, such as language capacity. And again, noting Nelson will dive deeper there with respect to our language access plan in the next presentation. It also includes implementing a new business intelligence tool that will enable the Health Connector to leverage existing data in more useful ways to monitor metrics that indicate disparities in eligibility and enrollment to inform future Health Connector policy decisions and practices. So I'll pause here as well before moving on to our fourth strategic area. Okay. And so in our fourth strategic area, Health Connector work is driving towards making sure the health insurance coverage that residents do obtain when they find their way to the Health Connector and make their way through the process provides the level of coverage necessary to access the services that individuals and their families need and deserve. We are focusing on using existing tools and relationships with our board and external partners to make sure coverage is comprehensive, while also raising awareness about current existing value available through the products offered on the Health Connector. Through communication campaigns, the Health Connector will work to ensure that the benefits of existing program designs, for example, no deductibles and lower cost sharing, at times no cost sharing through the Connector Care program, is something that our members are aware of and truly understand what that means, especially for individuals who may be new to the Connector Care program. Maybe they're joining us from Mass Health or as part of the Connector Care pilot expansion population. So again, making sure individuals are aware of all that their coverage currently offers them, as well as additional communications through our carrier partners to members that will be aimed at encouraging use of preventative services to reduce foregone preventative care. We also want to continue to elevate and raise awareness around the value that shopping through the Health Connector itself brings, recognizing that there is inherent savings when shopping through the exchange, both on the individual and small group platforms, with the ability to see all options before an individual in a single place so that they can make a decision based on their needs. So we will continue work, as mentioned, to educate on the value and peace of mind that shopping through the Health Connector brings, and encourage tactics that promote value across products, and continuing to iterate so that small employers can more easily identify plans that provide them with the value and coverage that they are seeking and need. So I'll pause again here before moving on to our next steps. And
Maren, can I ask a question? I defer to Eric, who has better manners than I, and raised his hand.
No, I've asked plenty of questions. I'll wait my turn. Go ahead, Nancy.
On the left-hand one, do we have data or hunches based on the kinds of questions we get from our members or people who are shopping that will allow us to focus in on what aspects of coverage they don't understand or that we think are underused, or are these just examples of things that we suspect are going on, or that because we take a public health approach, we think prevention is good, which I won't argue with. And if they're not, might we have data that could help us? It's a big topic and one that I think is worthy of exploration and attention. But I'm just wondering, like, how in a vast arena we'll focus on this.
Yeah, Erin, if I can take this one. Thank you for asking the question and just sort of pulling out the kernel of what's inside of there. So a few years ago, we did see data that showed that the lowest income people in Health Connector coverage often had $0 in healthcare claims on an annual basis. And that is extremely concerning in the sense that we know there are things people do need on an annual basis. I mean, if you're healthy and you don't have any prescription drugs, that's fine. That's could be a good thing for you. But for most people, they do need some sort of, annual cancer screenings, particularly for people of certain ages, et cetera. We grafted that data and those observations with other state data from the Department of Public Health that showed there are incredible disparities in, just to focus on cancer screening, by race and ethnicity as well as income. And then unsurprisingly, we also looked at DPH data that showed that the disparities in outcome in terms of cancer incidence and mortality by cancer are also, highly inequitable in terms of where they fall. So kind of following each of those steps of the continuum that we see that our lowest income people who do tend to draw more from communities of color are not accessing preventive care, which is free to them, and that has life-altering consequences in terms of your likelihood of being diagnosed with cancer and your likelihood of dying of cancer. So that's why this became a part of our equity work and our strategic plan here is what can we do with our carriers to make sure that all this incredible work the Commonwealth has done in investing and getting people into coverage is not for naught, where those people are following the rules, they're getting coverage, they're signing up, they're complying with the individual mandate, and then they're not actually benefiting from the fact that these screenings are available for free and can save their lives. So that's the data and the sort of the linear leaps we were making to get to this point being something we think the connectors can play a role in terms of really focusing health system energy and attention on.
Bella?
Along those lines, I think the other population that I'm always scratching my head on is the AP, especially now, is the APTC only population. I'm not understanding who they are and why they are just APTC only, especially since we've expanded up to 500.
Yeah, it's a good question. We have fewer APTC only people now because that expansion from 300 to 500% of the federal poverty level for connector care grabbed a bunch of them. Until 2021, the only APTC only people there were between 300 and 400%. Now, anyone of any income level can theoretically get APTC. The higher up the income scale you go, the less likely you are to qualify for it. But there are people, and because the way that the enhanced APTCs work has to do with what percentage of your income it would cost you to buy a benchmark, a silver plan in your area.
Yeah.
So there are people, I'll pick on the islands, where there's a very, very high cost structure for those premiums, and to buy a silver plan or anything else on the islands is extremely expensive. So there's people higher up the income scale who qualify for APTC. It's also true of older people because of age rating and the fact that they're charged higher premiums at all. So there are fewer APTC only people now than there were pre-connector care expansion, but they're still there and they can go higher up the income scale than you or I might think when we think about subsidy eligibility because of age and location.
Okay. I was just wondering if maybe some of them don't quite understand that if they just chose, because aren't some of these folks not enrolling in a silver plan in order to be eligible for the cost sharing reduction subsidies that have been expanded up to 500?
So I may need Marissa to jump in there, but I think anybody who's eligible for connector care gets kind of automatically placed into it by our system. So
Okay.
if you're outside of the reach of connector care, you're above 500%, you are free to pick whatever metallic tier you want, and your APTC travels with you. So it buys you, a different amount of a platinum plan versus a bronze plan just because their pricing is different, but you're free to go anywhere and there's no cost sharing reductions available for you if you're above 500%. So you don't need to be in a silver plan to to get something that you would otherwise qualify for.
Okay, so just to confirm, between 300 and 500, if I take my APTC dollars and I go and buy a bronze, because I don't realize that if I'm in the silver, I will get enhanced CSR subsidies. I mean, does that happen in Massachusetts? Because that happens in other states.
It does happen in other states. Marissa, I will need your confirmation here, but I think our system defaults to making you go into connector care unless you proactively remove yourself. And there are people in the past, at least, who used to periodically do that because they wanted to be with a carrier that didn't participate in connector care. So as an example, even a low-income person is, you know, I really want to be in Blue Cross Blue Shield because I have a mental health provider I've worked with for 20 years, and I will forego connector care just to stick with Blue Cross Blue Shield. And those people would wind their way out of it. But that was part of why we made all the carriers get in connector care, so people didn't have to make that trade-off. But Marissa, can you just confirm that my details are all correct there?
You are all correct there. If you go through the application and qualify for connector care, the shopping experience shows you connector care plans.
Okay, thanks.
Eric, is your hand still up?
Yes, thank you.
Sorry.
Thank you, Secretary. So I'd just like to bring to the forefront the topic of affordability. We've talked about equity, which is super important, and people understanding what their options are. We've talked about subsidies, but I'm talking about affordability, looking at the drivers of healthcare costs, not just how we subsidize it through state funds. I feel as though we really have a responsibility to take a deeper dive look at that. I know it's on the title of this prior slide, but I just want to make sure that we're giving it its due attention. As one example, I was in a meeting yesterday where I found out that 20% of prescription drug costs are now being driven by GLP-1 drugs. That's the Ozempics, Wegovy's, those drugs. And so it raises a lot of questions. One, what does it do to affordability of premiums? Two, related, are the designs what they should be? Some carriers are including weight loss drugs as well as diabetes drugs. Others are not. What's the right answer there? What are the long-term benefits and costs? And that all plays into affordability of plans. And so I just want to make sure that we've got our eye on the underlying cost drivers, that we're talking to the carriers about it, that we're talking to other partners like the GIC. I know they're so active every year and looking at best practices. Just want to make sure we've got our eye on that ball, because that's ultimately a crucial part of what we're trying to do here, provide affordable coverage to people. Do tiered networks make sense? Do limited networks make sense? What's the pros and cons of that? I feel like those are great conversations. I see Mike's got his hand up, and he and I have lots of conversations in these meetings about these things. I think they're healthy and good, and they push us forward.
No, that's great. And your point is very well taken. And that is something that we're kind of deepening our exploration of what our levers could be. It's not something we have direct control over, but I do think that there are tools, and I don't even want to say around the margins, I think that diminishes it, but I think there are tools that we could think more creatively about than we have in the past at some of those underlying cost drivers. Some of what I think you're seeing on this slide is us trying to kind of burrow into some of the tools we have to elevate and draw attention to plans that are successfully kind of beating the market on price. So I think there's some places there where I think there's some lower hanging fruit we can go after, but those broader conversations with our sister agencies are starting to deepen, for all the same reasons, we're reaching really problematic levels of unaffordability, particularly for people who don't have subsidies in play. So on the radar, and perhaps our team can take that back as a topic we could come back to the board with on a discrete conversation about, whether that's part of seal of approval or something else, just to really give it its due.
And I would say it impacts people even with subsidies, because we can't just continually just take on the additional costs, just because people get a subsidy doesn't mean that the costs underneath aren't increasing. Someone has to pay for that.
Absolutely.
So it's all of us.
Yeah.
Michael.
Thank you. So I just want to pick up on that point. we standardize the benefits, but I don't think we standardize the formularies, which allow the plans to manage how they're going to deal with the GLP-1s, particularly around the indications. So some could be pretty tight, keep it with diabetes. Others can be broader and expanded. I think Eric was referring to that. And I think the issue here is actually one of how risk adjustment is working. In other words, you could imagine a plan wanting to bid low could be much stricter on the GLP-1s. It could attract a bunch of people that didn't want them per se, and that could be good or bad depending on how you think that plays out and how risk adjustment is going. And so it gets tricky in the prescription drug space because we are talking about a particularly salient class, but there's a lot of versions of prescription drug formulary design that can alter which plans are appropriate for people. And there is a tension between wanting the plans to manage prescription drugs tightly to keep costs down, which I think is part of the spirit of what Eric said, but wanting to make sure that they give people access to the prescription drugs that they need. And that would be hard enough if there was just one plan, but because these things also influence the selection across the plans and risk adjustment tends to be imperfect, the whole managing of this becomes hard. But I do think we have to be careful about how prescriptive, maybe that's not a good word in the context of drugs, but how prescriptive we want to be in terms of managing what plans do to lower costs, because sort of the philosophy of the exchange is to allow plans to use different tools and people choose the ones that work best for them. So network, prior auth, formulary design, a whole bunch of things that they do. So it's certainly an area worth looking into, but I do think it's quite complicated and we have to think about what our core function is in terms of how much we want to manage how the market works.
I think that's a great point, Michael. And I think there's just a lot for us to unpack there in terms of thinking about that balance. So would love to come back to you and others for a deeper conversation on that.
Thank you, everyone. Any other questions, comments on this slide or any of the prior slides before moving on to next steps? Okay. Well, thank you so much for all of your thoughts. And, we will certainly take all of this back and likely return to you all, for future work in those efforts. So as we move forward, the Health Connector will issue quarterly milestone reports similar to the report issued this month and posted on our strategic plan website. The reports track the key milestones and work that the Health Connector is driving towards and the impacts the work is expected to have on our operations and ultimately the member experience with health insurance coverage. While we use this first year to implement the strategic plan and ensure that our day-to-day work and future projects embody its priorities, we recognize that there is also a need to establish baselines for the work that we have not previously tracked. And so we will use this first year to establish those baselines where it is needed. And you'll see that in some of those other milestone tracks, key measures of progress for that first year are more directional in nature, helping us set our own foundational understanding so that in future years, we are able to be more precise in setting how we expect to measure the impact of our work. Lastly, while work continues for 2024, we are already looking ahead to the work we anticipate tackling in 2025 with the intention of setting 2025 work tracks in advance of the start of the next calendar year, and of course, engaging with you all during that process of setting those work tracks. So happy to again pause and take any final thoughts, questions, comments, but really appreciate all of the support.
Thank you, Erin and Nuri and the team. This is like incredible work, and it's great to see the strategic plan coming back as a living and breathing document. I had two thoughts. One is sort of prioritization. There's a lot here, so maybe it's an unfair question, but or to Audrey, or maybe you guys can bring back kind of, here's our long range strategy. Everything's important, but here are the things you can expect to, sort of interim milestones, or whatever you think would be an effective measure. And then I kind of want to reiterate Eric's point around affordability, and connect actually two of his points. So now I'm just repeating you, Eric, but, AI, in pursuit of affordability, both in terms of how we work and member experience, and all those things are important. But is there business intelligence in patterns that we can't recognize, but a computer can, that can help us better serve serve patients. And then to the point that Audrey made about how low income, how and when low income people access care, I think redoubling our efforts for those people who joined us or joined the connector as part of redetermination. They're going from, unfettered access. Admittedly, it's not easy to be a Medicaid patient in our state, but nobody stops you. And you might have, you might not understand a copay, you might not understand. And so I mean, I know I don't, and I've been in the business for 45 years sometimes, but so I'm kind of joking, but wish I wasn't. But I think redoubling our efforts at this point in time about making sure people understand what healthcare coverage really means to them is, it's kind of woven through it, but I kind of wanted to see that elevated a little bit more. So those were my thoughts as you were talking. But again, enormous thanks to the team for getting us this far. And I'll stop, and first Bella and then Nancy, based on the hands that I can see.
Thank you. I went through that strategic plan milestone report. I loved it. I was, and I think it's goes along with what Kate was saying, is that I would have liked to have like, oh, this is going to be in 2026. This is going to be in 2027. Just so, and maybe that aligns with your prioritization of what's more important, or what you're going to get done earlier versus later. And then the other thing that just kind of struck me, as I was also reviewing your list of board contracts, outside vendors, is maybe even having some sort of key or legend like these tasks are associated with these contracts.
That's really helpful. Thank you for that.
Yes, absolutely. And will note, my apologies, the milestone report is supposed to identify our most immediate work tracks that we're taking on actively during 2024. And of course, recognizing we won't wrap everything up in 2024. So we'll bleed into, probably the first half of 2025, and we'll iterate and build. So it will, of course, continue to grow and adjust. But my apologies for that not being clear in the document, and we will make sure that it is in future publications.
Thank you. Nancy.
Just to pick up on the secretary's point about focusing on the people who've been redetermined out of Mass Health onto the connector. As we explore some of those issues about why people aren't getting services, I think the more we can understand about really what's at the root of that. So for some people, it will be they don't understand their coverage. For other people, it could be they can't get an appointment. And as somebody who I think understands my coverage very well, and am privileged enough to be able to afford my cost sharing, it's really hard to get care right now. And then for many of our members, for many services, they're not getting, it's because they can't afford it. So each of those problems obviously has different implications.
Yes, thank you, Nancy, for elevating that. It's not just about understanding your coverage. It could be transportation barriers. It could be because people are working 3 jobs and they couldn't possibly find the time to go get, their mammogram. So I appreciate that. And that is part of kind of the more holistic view on what is going on here, that we have this significant population that is not even touching the healthcare system. We do all this work and investment to connect them to. So appreciate that. And we'll fold that into how we report this back to the board in terms of how we're working with carriers, our own data collection and understanding of that issue. Because I do think the solutions look different depending on this.
Right. Yeah. I mean, and some people may not be getting care because they really understand their coverage.
Yeah. I think Eric, and then Matt, then Eric. I can't remember the order, so you guys can slug it out.
Go ahead, Matt.
Okay.
Thanks, Eric. Actually, and it's I think just reiterating the point that Nancy made about understanding what the having a more textured understanding about what the what stands in the way of them ultimately using their benefits and getting the care that they need. And I would say at the GIC, we are thinking about much the same thing. And so it would be, as always, Audrey, helpful, I think, to me and perhaps to you to continue to compare notes on that. One of the things that we see and you perhaps see, though our programs are set up differently, is that a good deal of the individuals, the GIC members that reach out to us on a daily basis, particularly during our annual enrollment period, have very basic questions, like very basic questions. And this is an area where we're looking at AI tools, for instance, that can help us to interact with members, provide them some decision support tools. But look, I think we all acknowledge, as the Secretary acknowledged herself, insurance is all very complicated, right? And we can never underestimate how important it is to help people understand how to use it. It feels like a Sisyphean task, I think, at times, but I think the connector having this on your radar and on your work plans over the coming years, I think is really important, and as it is for us.
Thank you for that, Matt. And yes, we would love to compare notes on this.
I'll just add, I think there's opportunities to check a lot of these boxes if we continue to look for organizations who are leading. A lot of startups are doing great work. The carriers, if you ask them, and they have ideas on some of these topics. For example, if we're talking about access, there's a lot happening with virtual care, and the younger set who will be on the connector going forward, perhaps they are going to be, more open to having a primary care physician that's virtual than maybe I would. And so if we can recognize those kind of trends and leverage the technology, and oh, by the way, that's going to save money because it costs less when you're using the virtual care. And so I'm not saying it replaces what we do today, but I think there are solutions out there that can help. And there's no silver bullet, but you got to try all these things. And I think working with Matt and the GIC and others who are facing the same things, these are not unique to the connector, but there's certainly challenges that we have to continue to work on. And there are potential solutions out there that can help.
Great, thank you. Again, any other comments? This was really important. It's, this is obviously the team's work, but the board's responsibility to sort of guide. So I don't want to cut it off, but we also have other agenda items to move on to. I would encourage us to bring this back. I mean, I don't know what the right cadence is. I'll leave that to the leadership to figure out. But I think you can sense a pretty strong level of interest amongst board members. So we'd love to follow along with the progress and offer comments as we can. So.
Perfect. Thank you.
Good. Okay, so I will move us along to the language access plan overview, and Nelson is going to kick us off on that. Thanks, Nelson.
Good morning.
Good morning.
1 second as we advance the slides here. All right, here we go. So as Audrey and Erin mentioned earlier in today's presentation, and also this is a conversation that's come up in previous board meetings, so we wanted to provide an overview of language support, including what we know about individuals who need language support, the different ways that we provide language support, recent improvements that we've made, and a look ahead into improvement opportunities that we've identified for the future. As an overview, we know that this is an important area and it's tied to our Health Connectors equity goals. We know that individuals who don't speak English as a first language face additional challenges related to access and coverage. A 2021 report by KFF found that individuals with limited language proficiency, English proficiency, were over 3 times more likely to be uninsured as English proficient individuals. Also, as the board may be already aware, but we wanted to call out that we did publish our most recent version of our language access plan in November of 2023 that is available on our website. As we take a step back and look at the language support needs in Massachusetts, we understand that we serve a diverse population of Massachusetts individuals, families, and small business owners, which include individuals who need language support. A 2023 report by the Massachusetts Immigration and Refugee Advocacy Coalition found that there were more than 850,000 residents in Massachusetts who are limited English proficiency speakers. And note in here that the top 5 languages listed are in line with the languages that we're targeting as we continue to strive towards future improvements. In terms of language support, Massachusetts residents can engage with us or receive information from us via various channels, which are all opportunities for us to provide language support for limited English proficiency speakers. These channels include electronically, where members can visit our homepage or info site that's managed by the Health Connector, also our HICS application, our member portal, or even emails and text messages. We also interact with members over the phone, in writing, in person, or through advertisement and outreach materials. Sorry. Wanted to call out some recent improvements that we've made related to our language access, including some that Audrey mentioned, translating our HICS application and HICS generated notices to Portuguese, updating our interactive voice response, our IVR, where we welcome callers in our top 5 languages. And this allows callers who speak one of these languages to quickly bypass the IVR. And it also informs the agent on the receiving end of the requested language so that they can quickly connect them with an interpreter. And just to call out, our contact center currently supports English and Spanish with bilingual agents. We also recently translated our enrollment and billing emails and contact center generated notices to Portuguese. Lastly, for individuals who are deaf, hearing impaired, or speech disabled, we began using the 711 mass relay service that Audrey mentioned, which is a better experience than the TTY service that we were previously using. So on this slide, we want to go over an overview of our current state of language support. So outlining all the different channels that are available and the level of language support that's currently being provided. The key takeaways include the Health Connector is supporting English and Spanish for individuals and families across all channels, and we are continuing to add Portuguese. As you can see here, we have some work to do on the small business front, as currently we are only offering support in English across all channels, except for some targeted marketing and outreach materials. And this will be something that we'll talk about as far as future state improvements. And we'll get into this more on the next slide, but a strong option that we have available comes through our partnership with Navigators, who offer multiple support in multiple languages. And here we have an outline of the overview of the different languages that our navigators speak, which includes 29 languages across 22 organizations, and highlighting that this includes the top 5 languages that we're targeting. In terms of accessibility, our contact center also has several options available to support individuals who are hearing or visually impaired. This includes in-person options such as American Sign Language interpreter services, written options such as Braille and large font materials, and also the mass relay transition that we mentioned earlier.
Nelson, how much use of these do we have? I mean, it's wonderful to have them all available. Are there many people who take advantage of them?
It varies based on the options. As far as the accessibility, the previous slide, that is lower volume, whereas the language options for individuals who call in and need support in a different way, obviously would be much higher. But that might be a good segue into this current slide as we think about future improvements, because the third item on this list, it kind of speaks to that, is we've identified that we do need to be more data driven and collect data to help us understand our performance in terms of language support as it relates to or maybe different in terms of individuals who do not need language support. But overall, we want to collect information about the customer experience for individuals and be able to view it specifically for individuals who request language support so that we can identify if there are any disparities in that experience. But again, that is something that we're aspiring towards in the future, along with soliciting member and advocate feedback to make sure we have the right priorities to match the needs, benchmarking against other state programs, including Mass Health, other state-based exchanges, and even commercial companies such as health insurance carriers who may be offering something that we can learn from and provide to our customers.
That's great. I mean, I think those are all really important things to be doing. So great that they're on the radar screen, and we'll look forward to seeing what you find.
Eric?
Thank you. Are we seeing any particular impact from the immigration challenges we see in the state? Is that impacting the connector at all? Are we seeing language barriers or access barriers? Is there anything that we've seen or anything that we should be doing differently to help with that situation?
We haven't identified that yet, but that is one of the drivers behind that third line item is, we need to be deliberate about capturing all this information and reviewing it just as regularly as we review, call volume and customer satisfaction and, all the other main metrics that we think of in terms of performance and customer experience. So that's part of the drivers to make sure we improve in this regard so that we can have a better finger on the pulse as those things are changing, that we can respond accordingly.
Yeah, my sense is the languages may be changing a little bit, but I don't have the data at my hands to know. I know there's a lot of Haitian Creole folks in the immigration population, and that may be a growing need. That's why I bring it up.
Yeah.
I think it will be right now. I think they're mostly on Mass Health, but I had a question. Instead of benchmarking against Mass Health, did you guys consider and reject partnering with them? It's kind of a make-buy decision. I have visions of, all of the state agencies in EOHHS. All of us have built language access plans. All of us have built, and there has to be some scale here that we're just not taking advantage of, even if it's a language line contract, across state government. And I realize that if you're responsible for a metric, you want to be able to control the inputs and the outputs. But did you guys spend much time on that, Nelson? Because specifically, to Eric's point about immigration, we're seeing people from countries we didn't expect to see people from, and if you talk to people at the border, there's like a world of people potentially trying to get here. So a little bit about what should be core connector work versus something we partner with, and then also the I mean, I have this mental image, so we'll fund healthcare for all to build capacity, and then the connector builds the same capacity. And is there, I think there's an opportunity here, but.
That is great feedback. We have not thought of, what are those opportunities to kind of leverage what other state agencies are doing, and can we
I mean,
collaborate?
maybe start with Mass Health. I mean, you guys kind of toil in the same vineyard, and it's language skills explaining complicated stuff, and it's personal stuff, your PHI, and also how much money you make, and do you see a psychiatrist that might influence you, those kinds of questions. So it seems like we should at least look at that, because this is a lot of work, and if Mass Health is insuring almost 2 million people, and you're insuring, I've lost track of the number, but 130,000 people, there has to be some synergies, I think.
Yeah, absolutely. And I think, this might be a poor way to phrase it, but by benchmark against, really what we're trying to do is learn from these different areas where there might be organizations that have advanced and, have some best practices that we can apply. But to your point, we can also think about, are there opportunities for collaboration?
At the risk of being a petty bureaucrat, if we think about the unit cost of this, is there a way to drive it down?
Yeah. I would say the mass relay piece is an example of that, because that is a service that is available throughout the Commonwealth that we, prior to this recent improvement, were not leveraging. And it's a better customer experience without us necessarily procuring something new. And eventually would mean that we no longer need to use and manage the TTY devices that we were using instead.
Matt, you want in? Yeah.
I would just add us to that list too, at the GIC, because we've been, all responding to the executive order here, and giving this a good deal of thought. So there's a lot of common themes to what we're doing as well. And to your point, Madam Secretary, I think there's some efficiency or alignments here that we can probably find as payers or payer channels.
Absolutely.
And we're all submitting reports to the same governor on the same challenge. So it's great. On our team, it's Tammy Siegel, who's the Deputy Chief of Staff. If you reach out to her, she's got our language access plans as her work. And I think we've done a nice job with it. Also, we have, the Mass Commission of the Blind and the Mass Commission for Deaf and Hard of Hearing, and both of those agencies have built up specific skill sets you could potentially benefit from.
That's great. Thank you, Secretary.
Good. Any other comments? This is great. All right. I think we're going to move on to the federal policy updates, I guess, with the sense that it's written in invisible ink because it could change. But let's see. Unless there are other questions. Okay. I think it's Marissa, correct? Oh, sorry. Did I kill your last slide, Nelson? I didn't mean to.
No, I think we covered it.
Out of my mind, so
yeah,
okay.
I think it's okay. I think we covered it. Just wanted to wrap up saying, we will come back with periodic updates as we continue to make progress. We're slated to have another update to our language access plan for 2025. And in the meantime, we are, working on how do we turn these high-level improvements that were on the previous slide into real action plans to help us get there.
Wonderful. Thank you. Sorry,
and Secretary, could I also just both thank you, Nelson. It's really great to hear everything that's going on. So thank you for the work that you and your colleagues are doing. There's obviously a connection between this topic and the one we talked about in the previous section about why people may not be availing themselves of benefits in their coverage too. So, assume we'll try to bring that lens to that analysis too.
Yeah.
Yes.
Unless there were any questions, I will pass it over to Marissa.
Thanks, Nelson.
Great, thank you, and good morning. So today I'll share brief overviews of recent regulatory actions taken by the Biden administration. These regulations were promulgated by the U.S. Departments of Health and Human Services, Treasury, and Labor, as well as the Consumer Financial Protection Bureau, and can be broadly categorized into 3 buckets. The first three rules here impact marketplaces, healthcare, and traditional health insurance products. The next two rules listed govern other kinds of coverage arrangements beyond the ACA, and the last rule is a consumer protection rule around medical debt. The first 5 rules on this list are all final rules, and the Health Connector offered comments in support of them all. The medical debt rule is in the proposed rule phase and was just published on Tuesday, so we're still in the process of reviewing it. The Notice of Benefit and Payment Parameters is a lengthy annual rule that covers a wide variety of topics related to administration of the Affordable Care Act. This latest iteration of the rule included a number of provisions of interest for us. First, state-based marketplaces will need to adopt federal network adequacy standards as part of their plan certification process beginning for 2026. While the Health Connector has its own network adequacy standards today, especially for connector care plans, and the Division of Insurance assesses network adequacy more broadly, the federal standards will require some work to implement, and we're working closely with DOI on this topic and with CMS, who's providing technical assistance to states to make sure that they're all successful. Second, this rule includes a variety of provisions designed to streamline eligibility and enrollment processes in marketplaces. For example, CMS made permanent a special enrollment period for individuals up to 150% of the federal poverty level, and updated requirements around noticing when someone has received tax credits in a prior year but not filed their tax return for that year. Implementation of updates required to effectuate these changes is underway. Third, CMS outlined minimum standards for all marketplaces in areas like open enrollment periods and call centers to create a consistent floor as more states seek to create their own marketplaces. And then lastly, there were a number of provisions in this rule that related to the ACA's Essential Health Benefits Framework, which ensures comprehensive coverage is available in the individual and small group markets nationwide through so-called benchmark plans that are designated by each state. CMS revised the standards for state selection of these benchmark plans to address longstanding requests from states to reduce administrative burdens. And they also changed requirements around when a state must defray the cost of state mandated benefits so that it's more intuitive for states to determine their liability. In terms of consumer protections around essential health benefits, CMS finalized that prescription drugs in excess of those covered by the state's benchmark plan are all considered essential health benefits, not making sure that coverage and cost sharing rules apply to all drugs covered by the plan and not just those that are also covered by the benchmark plan's formulary. Finally, CMS will allow for routine adult dental services to be considered as essential health benefits in benchmark plans effective for plan years 2027 and beyond. It's still a little bit unclear how this would be implemented by an interested state, but we were glad to see that CMS acknowledged that many people really struggle to get needed dental care. I'll just pause there. That was a lot of ground to cover in this one particular rule before I move on and just see if anybody had any questions on those.
Marissa, could you just remind us of the last bullet, like what that is?
Yes, so those the essential health benefits pieces were the items related to how states set a benchmark plan to ensure that there's kind of a standard level of coverage across plans offered in their individual and small group markets. It has specific cost sharing requirements and coverage similar to some of the features of our minimum creditable coverage standards, but on a national scale. And so they made policy changes there for administrative reasons for states and also for consumer protective reasons to make sure that all drugs are covered by those cost sharing provisions and to think about how dental can fit into that.
And so the implications of that are, in my view, good nationally, but probably don't affect us because we're already doing them.
Well, some of them I think will impact. I think it's unclear, as I noted, how states could implement the routine adult dental component in updating their benchmark plan. So I think that we would need a little bit more information there, but it does provide additional pathways to states to think about how they are creating a kind of standard set of coverage expectations across their states.
Yeah, I guess I'm trying to tease apart like what's the impact nationally with what's impact on us.
Mm-hmm.
Not to be overly parochial, and of course we care about everyone, but
Yes, I would say, you know, my sense was that this widens the toolbox, and then each state will need to figure out how they use those tools. So I think we'll have to have a discussion with DOI and other stakeholders in terms of what that could mean for Massachusetts and what of these different tools might be adopted. But I think that the essence of the rule changes from my perspective were to empower states to use the essential health benefits framework to make sure that consumers are getting what they need.
Okay, can't argue with that.
Would it be an impossible task? I don't want to ask you to bring us the broomstick of the Wicked Witch of the West, but could you bring, like, I mean, I think of 10 essential benefits and here's how they're paid for. Like, could you just bring us a grid, you know, or send it around to, or we could talk about an upcoming meeting if something's going to change in our state or what we're already doing that doesn't need to change. And particularly you said something briefly about dental, which is always a pain point, pun intended, I guess. But it would be good to understand that because it, you know, the dental always comes up on the Mass Health side when we're looking at budgetary issues. So it'd be kind of good to understand that. So.
Absolutely, we'd be happy to do that. And just at a very high level, the 10 essential health benefits are the things you would expect. You know, medical care, hospital care.
Well, I know the 10.
Yes.
But maybe just like I have like this like chart. Here's the 10. This got added. This got taken away. This is handled differently, and we're okay. Or in Massachusetts, we want to understand these two things better, and we'll be watching that.
Absolutely. You know. Yep, we can do that.
Thank you. Marissa, I'm sorry to interrupt. We at the Division of Insurance can help you with that. Niels Putov, our Director of the Bureau of Managed Care, would have all that information, and we can help Marissa make that available.
Yeah, I think we probably carry it in our heads, but probably couldn't, as you just saw, spit out a sentence about it. So,
okay, great. Yep, thanks. Happy to do that, and thank you, Rebecca, for that offer.
Good, thanks.
So a second recent rule modified the definition of who can be considered lawfully present in the United States and therefore eligible for marketplace plans and subsidies. Primarily, the rule made it possible for recipients of Deferred Action for Childhood Arrivals, also known as DACA recipients or DREAMers, to qualify for coverage. We're actively working with Mass Health and the HICS and Optum teams to implement these changes for November 1st when they become effective. The proposed rule had include parallel changes for Medicaid agencies as well in changing these definitions, but the Medicaid definitions were not finalized. So we will be considering these individuals differently than Mass Health will, which complicates implementation a bit. Also of note, Mass Health does provide coverage to DACA recipients using state funding today. So that's a pathway to coverage that's not available in other states that we're accounting for in our implementation planning. We'll use both direct and broad-based messaging to get the word out about these changes, as we know that immigration-related blocks are a driver of our uninsured rate, and reducing that disparity in access to coverage supports our health equity goals. We'll look to target our messaging geographically as well as in non-English media outlets, and we'll work with navigators, community organizations, and immigration groups to make sure that they're aware of these changes and letting their communities know. In May, the U.S. Department of Health and Human Services finalized a rule implementing Section 1557 of the ACA, which outlines healthcare non-discrimination provisions. The first Section 1557 final rule was published in 2016, followed by a second final rule in 2020 that rescinded large sections of that 2016 rule, limiting the scope of civil rights protections for patients and consumers. This latest final rule restores and expands upon the 2016 interpretation of Section 1557. The newly codified rules apply to any healthcare program, service, or activity that receives federal funding, including ACA marketplaces and the issuers that participate in them and receive tax credits toward member premiums. Because of our emphasis on equity, the Health Connector maintained its existing non-discrimination notice language and policies, despite reduced regulatory requirements in 2020. And staff are reviewing our materials against the new rule and preparing to update these notices, policies, and procedures, as well as to train staff on these updates. We'll also plan to connect with our carriers to share our understanding of the rule and details on our implementation approach as they develop. Also, I will just note 3 lawsuits have already been filed taking issue with this rule, asserting that doctors who refuse to provide gender affirming care would be penalized under its provisions. So we'll monitor any developments coming out of the courts with regard to this. I could just pause for one moment before I move on. Questions? I can move into the second tranche of regulations related to alternatives to ACA insurance markets for small groups and individuals, respectively. This first rule is about association health plans, or AHPs. These are arrangements that allow small groups to band together, pooling their employees to become a large group for rating purposes. Large groups aren't subject to the same kinds of rules as small groups. They aren't required to adhere to the essential health benefits framework we discussed earlier, and they use different rating rules. In late April, the Department of Labor rescinded a 2018 regulation on association health plans after large parts of it were invalidated by a U.S. district court. The 2018 rule would have made it easier for AHPs to draw lower risk individuals into an association and leave higher risk individuals in the small group market. While Massachusetts has state laws that would have prevented AHPs from circumventing merged market rules, federal policies seeking to advance them can still have negative impacts by causing confusion and generally undermining principles of healthy insurance markets. And on the individual side, we have short-term limited duration plans. They're not considered individual market coverage, and again, don't have to cover essential health benefits or follow the ACA's individual market rating rules, which often makes them attractive but risky low-cost options. A 2018 regulation allowed short-term plans to last up to a year, similar to traditional insurance policies. The April 2024 regulation amended that to a 3-month term with the possibility of a 1-month extension, so no more than 4 months. The rules also required prominent and clear disclosures about the limitations of these plans and the alternatives that are available through marketplaces. As with the AHP rule, state law would have insulated Massachusetts residents from the impacts of short-term plans, but they can still lead to confusion and the potential for consumer harm. And then finally, earlier this week, the Consumer Financial Protection Bureau issued a proposed rule that would restrict the use of medical debt information in credit reporting. Based on their research showing that medical debt is not a good predictor of whether someone is likely to repay a loan, they've proposed that medical debt should be excluded from credit reports. Further, the rule would ban the use of medical devices like wheelchairs or prosthetic limbs as collateral for a loan, as well as prohibit lenders from repossessing medical devices due to non-payment of a loan. So comments on this are due in August, and the rule is expected to be finalized early next year. So let me pause there and see if there are any questions on those last couple of rules.
Not questions, but just an observation of what a productive regulatory season. And I wish I could put balloons flying on my screen.
Yeah.
So.
Yeah, really. The medical debt one in particular, I mean, it's less of an issue in our state, but even if you think about, high deductible plans, I think this is a really great thing. So.
Yeah. Yeah, Matt, that's good. That's what I'm going to do. Just...
Yeah. If you think about sort of it's almost like Dickensian to think we're going to that people were going to repossess artificial legs or something, or glass eyes. I mean, it's just oh dear God, what a crazy system we live in. Okay.
Well,
probably not a productive comment from the chair. Sorry, but
that made me think about yachts, Secretary, but I wasn't going to go there.
Yeah. Well, thank you. I have PTSD. Or I don't know if it's not even, there's no P, it's T, it's active.
It probably stands for present in your case.
Yeah. Sorry, Marissa, you're trying to get us through important policy updates.
No, I'm happy to engage in the dialogue here. So to Nancy's point, it's been a very busy couple of months in terms of federal rules, but we do expect that pace to slow down as the election approaches. Regulations finalized near the end of an administration's term may be overturned by Congress through a law called the Congressional Review Act. So the aim was to finalize these rules now In case of an administration change, that would mean that the new administration would need to engage in the rulemaking process to amend them. So we'll continue to implement the provisions that are applicable to our work. And as Audrey noted, we'll return to the board in coming months with an update on potential policy implications of the November federal elections.
Great. Any questions for Marissa or the team? Okay, I think I'm very proud of my time management today. We have one more item, which will result in a vote, and I better check my notes so I set this up right. So it's a presentation on Smartronix Inc. And this will include a vote, and it's going to be in, Michael's going to present it to us. Thank you.
Great, thank you very much. Good morning, everyone. The Health Connector is seeking approval through a vote to expand our utilization of Amazon Web Services, commonly AWS. And this request covers 3 work orders through a Commonwealth-approved reseller, Smartronix. For background, as Audrey mentioned, we've had an active work order with Smartronix for AWS cloud hosting services since 2017. This work order has been renewed annually, including through a board vote back in June of 2022. We leverage AWS because it offers us a broad range of cloud-based technology services that best align with our strategic goals and our operational demands. And it continues to expand as to meet our ongoing business needs. Our current use of AWS hosting services includes data storage and virtualized desktops, as well as public-facing tools, including Get an Estimate, the Appeals and Ombudsman team requests, and the ConnectWell application for Health Connector for Business. In addition to continuing these services, we're also looking to expand our internal business intelligence that Erin walked through through our strategic plan review with our new data analytics and reporting platform, as well as looking to migrate our physical servers and data into the cloud. Specifically, Smartronix is on state blanket RFR 1621, which covers infrastructure as a service and platform as a service. By leveraging this state blanket, we receive all the benefits of a vendor procured through a statewide process with all the contractual protections that come with a state contract. Additionally, as a certified reseller on 1621, Smartronix offers a 16% discount off list price for all Massachusetts state agencies. The cost of these work orders has been estimated based on individual project projections, with a total not to exceed cost of $953,000, with the hosting for current services estimated at $500,000, the data analytics and reporting platform at $213,000, and the migration of our physical servers at $240,000. And these costs have been included in our fiscal year 2025 budget. Are there any questions before we move to the vote?
I have one question on the data analytics and reporting platform. What is the data that we're actually talking about? What's that data source?
It's multiple sources. It includes our eligibility data from HICS, as well as our enrollment data from Softheon, our contact center data from Accenture, as well as other data that we may get from other agencies. So it's kind of aggregating that data as well as moving it to a business model view. So when someone is asking a question about how to inquire about a particular data element, that you'll get a consistent answer each time. So that's kind of the goal of the overall enhanced BI tool.
Thanks.
Other questions?
Other questions, comments? Okay, I think we should move on to the vote. The language is there. I'm sure there's something I need to do, which is
I think
Is
we need
this
to have a
roll call?
motion. Yeah.
Oh, yeah. Okay. Yeah. Okay. I'm looking at my notes. We need a motion, which I think Michael's going to offer us.
I motion that we take a vote.
Thank you. Can I get a second?
Second.
Thank you, Feline. And Kathy, is this a roll call vote or can we do a show of
No,
hands?
it's a roll call vote, Secretary.
Of course it is. Of course it is. So Kathy, can you call for the roll call?
That'll be my pleasure. Rebecca,
Yes.
Michael,
Yes.
Elaine,
Yes.
Bella,
Yes.
Eric,
Yes.
Martha,
Yes.
Robin,
Yes.
Secretary,
Yes.
Nancy,
Yes.
Matt.
Yes.
Thank you, everyone.
Thank you, Kathy. The motion passes. And now I need a motion, or the vote, or the recommendation passes. Now I need a motion to adjourn, which is always a happy one.
So moved.
Thank you, Matt. Any second, Nancy?
Yeah, second.
Thank you. Kathy?
Rebecca,
Yes.
Michael,
Yes.
Elaine,
Yes.
Bella,
Yes.
Eric,
Yes.
Martha,
Yes.
Robin,
Yes.
Secretary,
Yes.
Nancy,
Yes.
Matt.
Yes.
Thank you, everyone.
Terrific. I want to thank the team for all their hard work in preparing the materials, for my colleagues on the board for a great dialogue. Audrey, any comments before we leave? It's a beautiful day out there, it looks like. So hope people get a chance to enjoy some relaxation over the summer. The New England summers are beautiful but brief. Any closing thoughts, Audrey? Are we ready to go?
Ready to go. Thank you everyone so much for the engagement and support. And thank you, Secretary.
Good to see you all.
Thank
Have a
you
great day.
all.
Take care.
Thank
Thank
you.
you. Bye, everyone.